Understanding eye pressure and the floor set by venous pressure glaucoma is caused by high pressure inside the eye, intraocular pressure, IOP. Most glaucoma surgeries work by opening new drainage routes for the fluid in the eye. Many modern procedures, known as minimally invasive glaucoma surgeries or MIGS, create openings in the natural drainage system, so fluid can exit through small veins on the surface of the eye, the episcleral veins. A key point is that these episcleral veins already have their own normal pressure, the episcleral venous pressure, EVP, and you cannot drain eye fluid below that pressure. In other words, EVP sets a physiological floor for IOP. If the eye fluid pressure tries to go much below EVP, there is no pressure gradient to drive flow, so it bottoms out. Classic equations for eye fluid, Goldmann's equation, even show that IOP equals the outflow pressure plus EVP. In practice, this means no matter how much we open the drainage, the pressure cannot drop much below the level of the veins. Eveyscleral venous pressure is normally about 8 to 10 mmHg in a healthy eye, so even a perfect trabecular bypass or canaloplasty can only lower IOP toward that range. How MIGS and canal surgeries work. Trabecular meshwork-based MIGS, like eye stents, trabectome, Cahook dual-blade GAT, and Schlemm's canal surgeries, like canaloplasty or hydrous stent, all aim to reduce resistance by removing or bypassing the trabecular meshwork and inner wall of Schlemm's canal. Once those are opened, aqueous fluid flows through the normal canal and out through collector channels into the episcleral veins. In effect, these surgeries restore the natural pathway. Because the fluid still drains into the veins, the eye can only empty out until the pressure equalizes with the venous pressure. As one review explains, even a full 360 degrees trabeculotomy can only lower IOP to as low as episcleral venous pressure. In other words, if EVP is 9 mm, the IOP usually cannot go below about 9 to 10 mm from these procedures. Because of this limit, MIGS techniques are best for moderate IOP reduction. A recent evidence review noted that MIGS typically cannot achieve extremely low IOPs since they do not bypass the episcleral venous pressure, EVP, usually 8 to 10 mmHg. In fact, most MIGS studies report IOP only dropping into the mid-teens mmHg range. For example, one long-term series found that trabectome, an ab interno trabeculotomy, reduced IOP by about 29%, e.g. 23 to 16.5 mmHg. Whereas a trabeculectomy, a traditional surgery, could reduce IOP by 40 to 50%, e.g. 24 to 12 mmHg in similar patients. In plain language, MIGS could drop IOP from 23 to around 16 to 17 on average, whereas a filtering surgery often got pressures into the low teens. Patients and doctors should understand that this floor exists. If one needs very low IOP, for example in advanced disease where pressures in the single digits may be desired, simply opening the trabecular outflow may not suffice. By contrast, surgeries that divert fluid to low-pressure reservoirs, like a bleb, can go well below venous pressure, as we will explain below. Evidence from clinical studies. Clinical studies of micro-invasive surgeries support the idea that outflow is limited by downstream resistance. For instance, surgeons often look at the episcleral venous fluid wave, EVFW, during angle surgery. This is a sign of fluid flowing into the veins. If the wave is strong and widespread, meaning many collector channels are open and EVP is not obstructed, patients tend to achieve lower IOP after surgery. In one study of trabeculotomy, trabectome, eyes with a clear, extensive EVFW, good flow, had a mean IOP of 13.3 mmHg at 1 year on only about 1 to 2 eye drops. In contrast, eyes with little or no fluid wave, suggesting poor distal outflow, ended up at 18.4 mmHg on nearly 3 medications. In other words, when the path to the episcleral veins was effectively narrowed or pressured, the surgery did not lower pressure as much. Similar findings came from gonioscopy-assisted trabeculotomy, GATT. The greater the spread of the episcleral fluid wave during surgery, meaning more open veins, the lower the postoperative eye pressure and the fewer medications were needed. These reports reinforce that if the eye's veins or collecting channels are compromised, or if EVP is high, simply unblocking the trabecular meshwork won't achieve very low pressures. Conversely, high EVP can blunt the effect of trabecular surgeries. In practice, eyes with naturally high episcleral vein pressure, for example from vascular congestion or blood abnormalities, are known to respond poorly to MIGS. For example, Eyes with conditions like Sturge-Weber syndrome, carotid cavernous fistulas, or severe thyroid eye disease often have IOP at or above the level of their elevated EVP, and standard outflow surgery usually fails to drop it much further. While large trials on these exact patients are rare, the logic is clear. If EVP is already 15 to 20 mmHg in such cases, any surgery draining to those veins will likely leave IOP still high. Surgeries that bypass the EVP floor. When the goal is to lower IOP below the episcleral venous pressure, surgeons turn to procedures that divert fluid away from the conventional venous route. The main options are trabeculectomy, tube shunts, and cyclodestructive treatments. Trabeculectomy, traditional filtration surgery, creates a new channel from inside the eye to a fluid reservoir, bleb, under the conjunctiva, the soft tissue covering the eye. Because the fluid drains into this bleb instead of the episcleral veins, the IOP is no longer tied to venous pressure. In fact, filtered fluid can be absorbed by the tissues or lymphatics at a pressure often well below normal EVP. Clinical studies show trabeculectomy commonly achieves very low pressures. Mean postoperative IOP in one long-term study was only around 7 to 8 mmHg, and most patients easily achieved pressures 10 mmHg on very few medications. This is about 5 to 6 millimeters lower than typical glaucoma drains. In other words, trabeculectomy bypasses the EVP floor. Its power to lower IOP comes at the cost of more risks, like bleb leaks or hypotony, but it is the standard choice when very low IOP is needed. Tube shunts, glaucoma drainage devices, place a small tube from the eye to a plate implanted under the conjunctiva. The plate forms its own bleb-like space around it. Like trabeculectomy, the fluid leaves the eye to a tissue space rather than to the venous circulation. Over time, the new bleb capsule develops moderate resistance, but typically tubes achieve IOP around the low teens, often 11-12 mmHg in published comparisons. For example, a MIGS study found tube patients averaged 12 mmHg on medications at 5 years, compared to 7 to 8 mm in trabeculectomy. Again, tubes are far less constrained by EVP than MIGS, though usually not quite as low as a perfect trabeculectomy. Cyclodestructive procedures like cyclophotocoagulation work differently. They reduce the eye's fluid production by partially destroying the ciliary body, the tissue that makes fluid. These do not depend on outflow at all, so there is no venous pressure floor to consider. Cyclodestruction often achieves moderate drops in IOP, commonly into the mid-teens or lower, and can be repeated. It is generally used when other surgeries have failed or are unsuitable. Some newer MIGS-like options also bypass EVP indirectly. For example, the Zen and PreserFlow gel stents are tiny tubes placed into the eye that drain to a subconjunctival bleb, similar to a trabeculectomy. These work like mini trabeculectomies and thus can achieve lower IOP than trabecular MIGS. They still depend on forming a bleb, so they carry some of the same healing issues as trabeculectomy. Other experimental approaches, like suprachoroidal shunts, also avoid draining to the episcleral veins altogether, choosing the right surgery. When EVP is high. So how should a patient and surgeon use this information? First, high EVP can often be suspected from clinical clues even if we do not measure it directly. Look for very red, dilated episcleral veins on eye exam or blood in Schlemm's canal seen on gonioscopy. Certain histories, like thyroid eye disease, Sturge-Weber, or neck vein obstruction, raise suspicion of high EVP. If a patient's IOP seems out of proportion to their glaucoma severity or to their medications, consider whether elevated EVP could be a factor. If we suspect or know EVP is elevated, we should expect that MIGS or canaloplasty alone may not reach target IOP. These procedures are still valuable if only a modest drop is needed. For example, reducing IOP from 22 to 17 might be worth a MIGS in a mild case. But if the target IOP must be very low, say quarter 12, or if the patient already has fairly high IOP despite maximum therapy, then a surgery that does not rely on episcleral outflow is likely a better choice. In practice, this means severe glaucoma or very high IOP, prefer trabeculectomy or tube shunt. These can reach lower pressures and can overcome even a high EVP. If a patient absolutely needs single-digit or very low teen IOP, or if previous MIGS have failed because pressure stayed high, a bleb or tube surgery is indicated. Moderate glaucoma or modest IOP goals. MIGS is still an option as long as the expected drop to the mid-teens would be enough to protect the vision. Many surgeons will try a trabecular MIGS first if the target is upper teens, but they must counsel that the pressure will likely flatten out around the EVP level. Borderline cases or uncertain EVP. Sometimes surgeons test the outflow pathway during surgery, for example by looking for blood reflux or flushing Schlemm's canal. If those tests show poor connection to the episcleral veins, the surgeon may abort the trabecular procedure and switch to a different approach, even in the same session, if possible. Combining approaches. In tough cases, a surgeon might combine MIGS with other steps, such as adding a limited filtering procedure or even doing both a tube and a trabecular bypass. Cyclolasers can also be added later if needed to help achieve pressure goals without additional incisions. In summary, patients with high episcleral venous pressure require careful surgical planning. Doctors may choose to bypass the floor by sending fluid to a bleb or reducing production. For example, if a person has Sturge-Weber glaucoma, you are more likely to plan a tube shunt or trabeculectomy up front, rather than a trabecular MIGS. If veins look abnormal and the IOP is stubborn, we lean toward filtering procedures. Discussing these options with an eye specialist ensures that everyone understands why one surgery is chosen over another. The goal is to match the patient's target IOP and anatomy with the procedure that can achieve that safely. Conclusion: Episcleral venous pressure, EVP, is a critical factor in glaucoma surgery. It effectively sets a floor on how low eye pressure can go when using the eye's natural drainage veins. Surgeries that drain into the episcleral veins, all Schlemm's canal or trabecular MIGS, and canaloplasty, cannot lower IOP below EVP. Clinical studies confirm that eyes with limited episcleral outflow or high EVP achieve only modest pressure drops from these procedures. By contrast, filtering surgeries, trabeculectomy and tubes, and fluid-reducing procedures do not have this limitation and can reach much lower pressures. When planning care, doctors should consider the patient's EVP level. If EVP is elevated and a low target pressure is needed, procedures that bypass or avoid the episcleral veins are generally preferred. This approach ensures the chosen surgery fits the eye's physiology, giving the best chance for success in each case. All links to sources are available in the text version of this article. You can find the full article at visualfieldtest.com. Thanks for listening. To check your visual field, click the link at the bottom of this article or visit visualfieldtest.com.